Sorry about that. We're really excited to have you join us today to discuss one of the crucial issues, and we're talking to members across the country about workforce issues, and one of those is healthcare costs. And so today we're really going to be talking with some experts on how to tackle healthcare costs and what some strategies to managing those rising costs while maximizing affordability for the employees. And this webinar is part of the Lutheran Services in America Strength and Service series, which is laser focused on examining and tackling the unintended consequences and uncertainties in today's climate, all with the goal of helping move your organization forward. So it's my pleasure today to introduce our guests for this webinar. We have our guest host from Portico, who's Ross Eichenberger, and he's Vice President of Business Development at Portico. Portico is a strong partner of Lutheran Services in America and is a ministry of the ELCA. They're one of the premier benefit firms in the United States that provides comprehensive, service-oriented, value-driven, and affordable benefit services. I'm also pleased to introduce Jon Nilson from Willis Towers Watson, or WTW. And Jon will share some strategic tactics and creative ideas that employers are using to manage costs, maximize affordability, and appeal to prospective employees. We will have time at the end for Q&A, so please feel free to enter any of your questions in the chat box at any moment. And we'll also take questions that are relevant as we're going through the different slides. So with that, I will turn it to Ross.
Yeah, thank you, Susan. Good afternoon, everyone, and thanks much for joining us. Just to set up our discussion this afternoon, we could go to the next slide. In the past few years, most organizations have taken action to mitigate the impact of rising healthcare costs. This slide shows a few of the examples of steps that employers have taken to control costs. A really key question for today is whether these steps will continue to enable organizations to effectively manage healthcare costs in light of the projected medical trend the next couple of years. Jon, where are healthcare costs likely to go?
Up. Pretty easy response there, Ross. I think we're expecting them to go up, and we'll cover some reasons for why that's going to happen as we go through. So if we go to the next page, what we're going to start with is cost management. And then we'll get into member affordability, because I think they're a little bit tied hand in hand. So the projection from WTW, when you talk, I'm an actuary by background with my fellow healthcare actuaries, is we expect healthcare trend to go up, but I think this does a good job of showing why. So what's shown here is a chart from our best practices in healthcare survey. We do it every year at WTW, and then some Bureau of Labor Statistics data. So if you're looking at the bar charts, what's set up here is what employers have told us they expected healthcare cost increases to be every year. So if you start back in 2012, they said 5.5%. And then you can see it comes down to below 5% for all of the years until we get post-pandemic in 2021. And we're expecting it to go up to 6% in 2023. What the line charts are is what the Bureau of Labor Statistics tracks for CPI, right? So inflation's been very high. So that's the CPI, or the light purple line, or the dark purple line. And then the orange line is medical CPI. So think of that as what it is as a basket of services for medical costs. How has that changed? So generally speaking, if we go back to 2012, that orange line's been above the light purple line. So medical trend has always been about double CPI, core inflation. You can see it crisscrosses over in 2018, then right sizes in 2019. Well, what happened in the pandemic in 2020 is, as we all know, a lot of things shut down for the health systems, and we saw inflation and medical CPI equal each other. And then core inflation skyrocketed the past 2 years, but medical CPI hasn't caught up yet. So really what's happened is core inflation hasn't worked its way through the healthcare system yet. One of the big reasons for that is a lot of the provider system. So when you go see your provider or you take a major system, they negotiate their contracts with the insurance companies every 3 to 5 years. So as these contracts come up for renewal, as we come out of the pandemic when they lost a lot of funding, they didn't make as much money, we're expecting them to right-size those contracts to respond to a lot of different challenges there that they're experiencing financially. And it's going to take probably 3 to 5 years for that to fully work its way through the system, as each provider system's contracts come up at different times. So to answer Ross's question, that's why we're expecting healthcare trend to come up. The provider systems lost a lot of money in 2021. They're still not doing so hot. And at some place in time, they have to break even at least or start making some of that money back.
See, John, let me jump in with a quick question. If core CPI eases over the next couple of years as we look forward, how might that mitigate the medical pharmacy trend over the next couple of years?
Yep, it's a great question. So I think the first thing on CPI, so typically when you look at where CPI was from 2015 even to 2020, we were talking low single digits, 1 to 2%. I don't think we're going to be living in that environment going forward, right? I think we'll be lucky if we're in that 3% environment. I do think as CPI comes down, what we'll probably see is medical trend come up for the next 3 to 4 years, kind of come back down. So it's back to the relation we saw before the pandemic, where we were talking maybe 1 to 2 percentage points higher on employer-sponsored healthcare costs versus CPI. But I do think there's some broader challenges that our health systems are going to experience from labor. So I'll give you an example. So I sit in Minnesota like the Portico team does, and the Minnesota Hospital Association, which is kind of an industry group of all the big health systems in Minnesota, they published a study that basically said right now they have a 20% job vacancy rate. So they have job postings that they can't fill. And a big reason of that is a lot of doctors are in the baby boomer generation. So as they retire, there's not enough people to replace them. There's going to be a big compensation gap that these health systems have to close. So I do think we're not going to see it come straight down. If CPI comes down, we're going to see medical trend continue to be higher because of some of those labor challenges. So with that context, we go to the next page. Because the other thing that you all as employers are facing is this huge increase in high cost claimants. So what this chart is here is this is tracking the number of claims per 100,000 members as measured by IBM Watson's market scan database. So that's a claims database of millions of claims that are gathered across the US nationally and tracked. And so what this is showing is the number of claims per 100,000 members. You're going to see the first big bar, that's claimants over 300,000. Then the second one is over 500,000, 700,000 and $1 million. So think that as an individual claimant. What you see here is this huge increase from 2012 to 2022 across all of these bars. And so what's happened is this huge increase in high cost claimants that our clients are experiencing that they weren't experiencing before 2012. So from a percentage perspective, if you take claimants above 300,000, it's over a 200% increase. Over $1 million over this time period is over a 300% increase. And often the question is why? There's two main factors. One is actually the Affordable Care Act, which doesn't make sense on the surface. What happened in the Affordable Care Act, as many of you employers who were sponsoring plans at the time knew, our employers could no longer keep lifetime maximums in the plan, saying once you're over $2 million, we're not going to cover anything, or annual dollar maximums. So the provider systems knew the employers were on the hook now and they could start billing a lot more for these high cost services, right? You go in 2010, if I had $1 million claimant, it was likely the member was going to have to pay for a substantial chunk of that. That was going straight to collections for the health system. The other big thing, which is all good news, is healthcare innovation. A lot of things are being cured that used to be fatal illnesses, particularly in cancer and oncology. So a lot of those services are now almost chronic conditions where members are taking medications, but those medications are very expensive. So as we cure more things, somebody has to pay the bill. And when we're curing some of these really complex issues, we see these huge increase in high cost claimants. And what this will mean for you as an employer, and we'll talk a little bit about this, it changes the cost equation game a little bit. I can share costs and increase my deductible or pass a contribution increase to make the employees pay more out of their paychecks. But if I get one more $1 million claim, it kind of washes it all away. So it's really changed the cost share equation for our clients when they're looking at, well, how do I cost share things when my high cost claimants are increasing at 200% over a 10-year period? So we'll talk a little bit about that, but that has been the big dynamic that we saw before the pandemic that we expect to continue in the future. So that's kind of the cost saving side there, or the cost management side. And then to wrap it all up before we get into the member affordability side on the next slide, what we'll cover is all the factors we're expecting to contribute to healthcare trend. So we talked about the first one. So here we're going to talk about unit cost and utilization. Think about the unit cost as when somebody goes in for a procedure, am I paying more today than I paid 3 years ago? Utilization is, are they using more of a service? So we talked about high overall inflation and increased labor costs. This is going to continue to be a problem. There's not enough people that want to be nurses, all of those things. So that's going to be a challenge on unit cost. Provider consolidation. As these health systems lost money in 2020 and 2021, they're saying, well, how do I right-size my cost profile? In Minnesota right now, what's happening is Sanford, which is a very large health system out of South Dakota, is trying to merge with Fairview. And it's causing a lot of dynamics there. We're seeing that across the country. It just depends on who. Escalating drug costs. So this has been a challenge for the last 5 years. The one thing we're starting to see that's interesting is like weight loss drugs. That's been the new thing that we're seeing, to the point where Jimmy Kimmel made a joke about it at the Oscars. Like, he made a joke about this drug called Ozempic, and people are like, what that is? Well, what's happened is people have been using that drug off label. It's a diabetic drug for weight loss, to the point where you can't even get it right now. There's a supply shortage. And there's drugs that have come to the market that treat obesity, which is great, but they're about $1,000 per dose. So we keep seeing this, like the pharmaceutical companies make their money, and that's been a continued driver of cost. Worsening mental health on the utilization side. Now, this is part of the pandemic, but this was going to happen regardless. So to give you a stat here, because I think I've been telling my clients, get ready because you're going to be experiencing this. We do a survey every 2 years where we actually survey employees on their preferences. And when we did this in early 2022, what we found is that 52% of millennials, I'm a millennial, by the way, like we're old now, 64% of Gen Z stated they suffer from anxiety or depression, compared to 16% of baby boomers. So as you see the older generation come out of the workforce and you're employing the younger folks, they just have more. So they just have a higher prevalence of mental health. And you add on top of that, the pandemic just accessing a lot more care there. Missed preventive care and non-emergency care, this is a continued issue, but it got much worse. And I'll talk a bit more about this on the next page due to inflation. So Gallup does a survey every year about people's preferences around healthcare costs. In the most recent survey, 38% of the US population said they deferred a healthcare service due to cost. Last year, that number was just about 25%. So think of that, like these people deferring things, is that you defer something, it just gets worse and more complex and costs money. And then this giant aftermath of the pandemic, which is kind of causing all of this disruption. So for all these reasons, we're expecting healthcare costs to go up. Sometimes my Portico friends accuse me of just being depressing with this. We are going to talk about what you can do about some of these things, right? We'll talk about the end. We're going to provide some context of why things are happening first. So with that, we're going to talk member side. So member affordability is very important as well. It's probably the 1A or 1B is cost management and affordability, and I talk to my clients. So I want to provide some context of what's driving affordability challenges, because it is different now for our clients. So the top tagline, we'll explain this here, is healthcare cost increases are no longer the challenge for our members. It's inflation and debt. So to give you some context on that, there's some charts on the left. So what's shown here, if you look at the small bar, that's a healthcare cost increase approximation using the Kaiser Family Foundation study that they do every year with employers. It's the combined increase since 2018 in deductibles and per paycheck contributions for single and family coverage. So an approximation of how much employers have shifted costs to employees. The bigger bar, that's the real wage growth as tracked by the Federal Reserve. So that's going to be income growth for a single person or family, household income or a family. So real wage growth since 2018. So that's after inflation. So what you're going to see here is that light bar for healthcare cost increases has barely dampened at all income growth. But what has happened since 2018, you see that big bar in 2019 where income went up almost $5,000 after inflation, has come way down as inflation has worn away income. The same thing happened with family coverage. What I think is interesting about this is we looked at this result for another briefing I did for employers in Minneapolis. We looked at it before 2018, though, and we did it since 2012. At that time, healthcare cost increases were eating 25 to 30% of income growth. So it's not healthcare costs anymore that are a problem with healthcare affordability. It's everything else. It's inflation and debt. So the chart to the top right, what this is the New York Federal Reserve tracks how much US folks have out in debt. So this is for 4 categories that they track: mortgages, student loans, credit card debt, and automobiles, so cars. So since 2018, that all the combination of that's 26% increase for the US population. I think of that as the other things that are pressing into people's paychecks that they have to pay out. And what's happened, if I go back to that Gallup survey, is a lot of income pressure, so I'm going to defer my healthcare services. So we have to think of that a little bit differently now as employers too, to say, well, if people can't afford to go see their provider, do I have to think differently about the impact my deductible has on that? Because to the far right, the bottom right is kind of the close here. Members not seeking care due to cost creates further risk for the employers and affordability issues. So there's a think tank, a pharmaceutical think tank that tracks this. And what they tracked is that the drug abandonment rate, so if somebody goes to get their drug filled, that they don't get the next drug filled, was 45% or higher if the out-of-pocket cost for a drug was $125. So think of that in your plans where you have a $2,000 deductible that resets every January and someone's getting their med filled. The number below $125, we're talking like single digits, we're down in the $50 range. And then it's 28% of millennials, I put millennials as they're the biggest chunk of the workforce now, stated they found it difficult to pay for healthcare. That number was 45% for Gen Z compared to 9% of baby boomers. So again, as the workforce changes, we have people that can't afford to get healthcare as much as the generations that we're losing, which means we have to think a little bit differently about how we make healthcare more affordable as well. So that's kind of the big pain points. Cost is going up, affordability challenges persist, not due to healthcare, due to everything else kind of going on in the economy, and we'll have to think differently how to tackle those challenges.
Say, John, a quick question. As you look forward, and you've talked about the income pressure, healthcare increases, where might this go over the next couple of years? And frankly, how bad might it get from an employee standpoint?
Yeah, I think it's going to be pretty rough for employees, but I do think the silver lining, we'll talk about it, is a lot more of our clients, if I take the macro issues we talked about, are coming back around in what I almost call the hamster wheel of benefit trends back to things like copay-based plans, right? And the reason why is if you think back to that bar chart with these huge increases in high cost claimants. Well, if I have $1 million claimant, it doesn't matter whether I have a $2,000 deductible or if that member paid like a $500 copay, like that's going to drive a lot of cost. So I think there's things out there that are helping people. The big silver lining of the pandemic was employers actually started to focus on mental health. Before the pandemic, I'm very transparent. A lot of my clients were paying lip service towards mental health trends. So I think there's a silver lining there. We address some of those core issues and we tackle those. But I do think putting some of those things in place will help employees afford and get the care that they need. And then I do think that employers will start pulling levers on things that some of our clients, if we go that are smaller, have done, but our larger employers haven't. They've thought, well, maybe I need to just narrow my network more or change my pharmacy formulary and some of those things. And they'll have to pull those levers a bit harder just to make it more affordable for everybody. So I think, Ross, that'll be the big trade-off. And then I do think it's going to be really tough for the employers to think about this as they have the wage pressure they have as well. If healthcare trends 7 to 8% and I have to pay 4 to 5% in wages, when before I was paying 2 to 3%, there's that push-pull too of where do I prioritize my dollars? And that's where I think you'll see employers do things that are a bit more draconian on the healthcare side if they have to really shift more into the wages. All right, so now what do we do about it, right? We don't want to just talk about problems. What do we do? So this is the traditional way I've talked about cost management with my clients. So what are historical strategies to reduce costs? So at the top is participation. Who's on my plan? So this is to manage costs. If you're covering fewer employers or dependents on your plan, that reduces costs immediately. So some things I think some employers will start considering too, back to your question, Ross, is Maybe they start saying, hey, if your spouse has coverage elsewhere, we won't cover you, right? Versus today, some employers, it's about 25 to 40, it's probably about 40% of clients today have a surcharge, so they make people pay more for that. But I do think they'll be prioritizing employees and things like that. If I go to the subsidization side, I'll go there. This has been the traditional way employers have done this, but I would say over the last 5 years, we haven't seen much shift here. Require employees to pay a larger share of total cost. This could be contributions, meaning out of their paycheck, or out of pocket, higher deductibles and copays. The labor market's been so tight, most of our clients have not pulled on this lever very hard. And if I go back to those affordability challenges we saw, it's not healthcare costs that are driving affordability challenges. So I haven't seen a lot of clients say I need to shift a lot more here. This efficiency side is where almost all of our clients are focused. And I think of this back to Pie Day. I think of healthcare costs as a pie, right? And it depends who's paying the share of the pie. So that subsidization component is how much do employees pay, but the efficiency lens is how do we shrink the pie? So cost goes down, and we'll talk about these risk pooling strategies, which there are different ways to do this. Stop loss is a way of risk pooling, right? Like pool that risk that's really high there. Try and get our employees healthier, which is a challenge. Drive better provider discounts. What medical care am I using? How do I steer people to higher value providers? And I'll talk about some innovative ways to do that. How do I have better medical and pharmacy management programs? So how do I get people to the right care at the right time to avoid waste? There was a study done a couple years ago by a pretty preeminent journal of medicine that said about 25% of all healthcare costs are due to waste. So how do I just bring some of that down? And then how do I just get better contracts with my vendors and bring the administration fees down? And I'll talk about a framework that you can use to kind of prioritize where do you focus first.
John, let me just jump in with a reminder. If any of you have questions along the way for John, just please throw the question in the chat and we will pause and take that along the way.
So if we go to the next page, now we'll start talking about how you can think about what to do from a cost management perspective. So here's our cost savings playbook. So it's a 3-step approach, and I think it works pretty well to figure out what to pull first. So the first thing is consider your current state, right? We have to measure where we're at. What's your size? So what can you execute, right? If I have talking to an employer that has 300 employees versus an employer that has over 10,000, we're talking about different tactics. Your demographics of your population, what's driving your claims experience. I'll tell you, I kind of know every client's top 5 claims drivers, I say, because they're all the same. It's cancer oncology, musculoskeletal, cardiology spend, digestive health, meaning gastrointestinal issues, is kind of popping up more. And then it's like maternity and diabetes. That's usually what we see. So what can you do to manage those? What are your savings targets and your time frame, which I'll talk about in the middle section? What are your labor challenges? Because maybe you don't want to pull too hard on healthcare because it's going to cause you broader labor issues. And then how much are you willing to be ahead of the pack? And I'll talk about one solution to the right that I would say is very ahead of the pack that I think more employers are going to start considering. So you start there, then say, what is our persona? Do we need claim savings now? Because if you need claim savings now, if I go back to that cost management framework on the last page, you're either, how do I get people off the plan? Or how do I shift more cost to employees? That's about the only thing you can really do to save money tomorrow. There's a couple of things around the edges, but that's really what you can do. Can I get claim savings in 2 years? Well, then I can try some different tactics there. Do I have no specific savings goals, this third one? And I'm just trying to be a prudent purchaser. I will say most of my clients are in that third category. And it's because our finance partners usually don't want to tell us how much to save because it's kind of scary. But everyone has, like when we get to the end of the year, everyone's like, I need to save money now. So it's how do I identify that menu of options? And then we have characteristics of who you are as an employer. I'm not going to cover all of these, but one I'll talk a little bit about is to the far bottom right. If your employee footprint is in mainly one geography, you have more things in your toolbox to pull to save money than our employers who are spread. Because you can go to your local providers and say, can I make a deal with you? Or do you have a plan offering that says, if I steer all my membership or most of it to you, will you provide me lower rates? It's very hard for our clients spread nationally to do that. But our clients who are locally geographically based, I think that is a really good opportunity there. and then determine your program's most likely to yield value. So what I did here is I pulled 3 things that most of our clients are considering from our best practices in healthcare survey, and one emerging trend that I'm putting on all my clients' radar, particularly my smaller clients. So the first one, 40% of employers are considering implementing a spousal surcharge. I think the first thing is, do you prioritize your employees or your members? And I see we got a question around ICHRA plans in the chat. That's my last item on the benchmarking, so I will come back to that question and talk about that. The second one, 52% of employers are issuing an RFP for pharmacy benefits management by 2024. I would say, just like if you, depending on size, a lot of our smaller clients, their pharmacies purchased through their medical carrier. A simple question to ask your medical carrier is, how much are our pharmacy rebates that you have, and how much are you sharing back with us? Because what we've seen as pharmacy trends have escalated substantially, pharmacy rebates, which is something that the pharmaceutical companies have negotiated with the pharmacy benefits manager. Pharmacy is like this black box of awfulness and healthcare costs, where they're basically giving them, it's kind of a kickback. That language is like a bad term legally, but it kind of is, to keep their drug on their formulary. And to give you some perspective, if you have a specialty drug, which is like an injectable drug, it's not a pill form drug that probably less than 1% of your members are taking, that rebate might be in the $2,500 per script level. And what we've seen is those rebate dollars have come up, and a lot of our clients haven't asked those questions. There's a lot of money on the table to just push your medical carrier on. Or if you're a bigger employer, you can go out to bid to the pharmacy benefits market. And my clients do that every 3 years, and we're seeing 15 to 20% savings on pharmacy costs just by doing that alone. So that's something that you don't even have to change design at that point. The third one we're seeing this big explosion in, we did this early on with Portico. They're one of the early adopters, is putting in a concierge program with integrated care management. So the traditional vendors in this space have been Accolade and Quantum. We're seeing more vendors pop in. So Included Health, who used to be Grand Rounds, does this now. Alight does it. A lot of vendors. And what they're really trying to do is to say, when that member calls in for an issue, maybe that's the time to intervene. And maybe I can steer them into a care management program, because the traditional programs they're waiting for a claim to be paid, which might be 60 days after a member went in. And then they're saying, oh, I need to intervene. And how they're doing it, the traditional programs through the medical carriers and like Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, they're calling people and hoping they pick up the phone. I don't pick up the phone if I don't recognize a number. I'm like, who the heck is that? So nobody's picking up the phone and nobody's engaging in the programs. So I think of this as flipping the model on its head. When a member's calling in, can we use that as an intervention point? So 51% of our employers are considering this. If we surveyed them 4 years ago, that number was about 20%. So this big explosion on this, and a lot of it is that high cost claimants are driving so much cost. So now the last point here, which is around individual coverage HRAs. And I see that, Joe, you asked this question. Only 2% of our clients said they were considering adopting it. So it's still a pretty low adoption rate. Now, I think the reason why it's low, because if you would have asked us this question 3 years ago, we thought this number would be a lot higher. I think the reason this number is still pretty low is our healthcare cost increases have not been too high. If you think back to where we've seen healthcare cost increases in the 2020, what we saw with our clients was 1.5%. Then went to about 5%, then went up to 6%, which we're not talking 8 to 9% trend yet. However, I do think if I was a smaller employer, and I've even talked to some large retail clients that I work with who think this is a good idea, I think it's a really good idea to consider. And the reason why is the risk pool. So if I go back to that slide where we had this huge increase in high cost claimants, well, the risk that you employ somebody that's going to be a $500,000 claimant is as high as it's ever been. And to explain what an individual coverage HRA is you can provide as an employer a healthcare reimbursement arrangement dollar amount, and then that member can use that amount to buy coverage in the individual market. And then that qualifies, you can still qualify under the Affordable Care Act's employer shared responsibility rules. So it's kind of a newer thing. The Trump administration passed that. But what that allows you to do is you're shifting the risk of your members into the individual market. So I do think more employers are going to consider this as they keep seeing these escalating healthcare costs. And we're seeing insurance companies dive back in to the individual market because the Biden administration has strengthened the individual market for those who don't have employer-sponsored coverage. So I think as healthcare costs go up and people are experiencing more of these $1 million claim events or $500,000 claim events, they're going to say, I just need to offer something and the individual market's better. I'm going to do that. And I'll come back to that point I mentioned on the characteristics. If you are in one geography or a limited geography, it's much easier to message to employees. Because the individual market, which is generally through, think of the Affordable Care Act exchanges or marketplaces, it's highly localized whether it's a good deal or not. Right? So there's some markets across the country where the individual market's great. Minnesota's actually got a pretty good individual market, but if I'm an employer where I have 20 different geographies, one might be bad and it's really hard to execute. So I think it's still something that hasn't been pulled as much, but I think that 2% number is going to consistently go up, particularly for employers with smaller headcounts. And Joe, to your question, if we're seeing people realize cost savings from individual coverage HRA plans, I think when we've talked to clients who have explored it, they're not looking to bring the current cost down. It's more about the trend avoidance in the future. Because I can put an individual coverage HRA and offer it to a member, and then it'll go up with maybe 3% per year, and I can communicate that and manage it. So think of it as in the retirement world, everyone moved from defined benefit plans to a defined contribution plan because I know what my cost is. It's not so much unpredictability every year of what my cost base would be. So I don't think we've seen employers go in there and say, I'm going to reduce my current cost by 10%. It's more of a future play that I can avoid the healthcare trend in the future. So that's cost savings with a lot of information, but this is kind of a 3-step approach that you can take with whoever is your current broker or whatever data that you have to say, what can we pull that are levers? And I tell all my clients come up with a menu of options now. So when finance or somebody asks, you're prepared and say, well, would you like us to consider this? So then we'll flip over to the affordability side, because I think having a playbook for affordability is just as important. So the first step's fairly straightforward, but a lot of my clients did not spend a lot of time on this until the last 5 years. What is our affordability problem? Is it the OOP here, out of pocket? That's what it stands for, out of pocket costs. So when people's deductibles, co-pays, when you go see your provider, is it per paycheck contributions or is it income? Right? Because I would say income is becoming more of the challenge. So this is an output from one of our tools at WTW. It's called our Member Affordability and Plan Optimization Model. And actuary came up with the name, so it's not very fancy. But what it does here on the left here is what we do is we say, well, let's start with what's the percentage of your members who might have a significant amount of their household income taken up by healthcare cost? And are you okay as an employer dealing with that? So if I take one of the bars, if I take that second bar in that's pretty high, what this is saying, we have less than 16% of our overall population who's going to have 1 to 2% of their household income consumed by healthcare. That's awesome, right? They can probably afford that. The question is, as you go down the spectrum there, when we're looking at 10% plus of your household income taken up by healthcare expenses, that can be challenging. And then if you look at the stacked bars, you can see what's the biggest chunk of that. So the dark purple is employee contributions, and the top set out-of-pocket spend. So generally speaking, when I ask my clients, what's the affordability issue? They say it's employee contributions on the per paycheck contribution side. But I think it's important to start with an analysis and ask your employees, what are they struggling with? Because then you might have different conversation points. To the right then is the same analysis, but then what we say is how many employees are in these bars, low, medium, high risk, because we tranche it based off of pay. And every time I do this for a client, it is a pay issue, right? So if you look at these bars here, are people over $100,000 per year? They're doing great. My people between $30,000 and $50,000, they're not doing so hot. And even my $50,000 to $70,000. And if the issue is pay, you can come up with some easier alternatives maybe to target the low paid population, where solving an affordability challenge may not be as much of a cost outlay as it might be if you're trying to solve it for everybody. So I do think generally speaking, your low paid people, and we've seen more clients interested in what's my low wage strategy to increase healthcare affordability, more so than we've seen in the past few years, just because it is administratively complex to do that, but it is important. So the first point here is diagnose the problem, which is similar to what we saw on the last page. And then if we go forward and we talk about the solutions, I would say think about your affordability gaps, prioritize and think about it a bit differently. So I've been challenging all my clients on their plan designs. Think a little bit more about what your employees actually need help paying for when they go see their provider. So this is a matrix that I've used to guide that conversation. And I think of it this way: if you go down in the categories, this difficult to predict and easy to predict. Every year when you enroll in benefits like I do, I have healthcare costs that are pretty easy to predict. I have a maintenance med. I take it every month. I know what it costs. And it's low cost because it's generic. But there's difficult to predict healthcare events that I'm like, well, if this happens, that could be really expensive, or it might be inexpensive. Like if I just end up with some ad hoc virus, I just go do a virtual visit and get like a Z-Pack and I'm good, right? But I also could have a huge healthcare event that's a huge cost outlay that I don't know about. And I think then you can prioritize how to come up with your plan designs for your members. So let's take some examples. If I start in the difficult to predict category, I would say that's what insurance is for, right? Health insurance is for things that are hard to predict, and it's for the things that might be expensive. So if I use the examples of care, there are major illnesses. I end up getting cancer. I have to go to the emergency room. I think an ideal plan design still is a deductible and co-insurance there. The reason why is that's most of your healthcare costs as an employer. When I get to the inexpensive things, this is what I think we've done wrong in healthcare. Like if I need to go see the urgent care and ad hoc prescription, that's pretty cheap. Well, a lot of my clients are like, well, people can save in their HSA for that. They get pre-tax savings. And then I look at the other side of who I'm talking to, and it's the executives of my clients with a lot of money. People with $30,000 aren't saving in their HSA. So I think what I've said is more, we have to think about the financial means of the member. Well, if they don't have financial means, we probably need to help them pay for that event with the copay. Or if they have financial means, there's places to save in an HSA. And then if you go to that easy to predict layer, if I'm going to an expensive thing, like if a member has a chronic condition and they don't have a lot of money, I think we need to help them pay for that. They need to go see their specialist or their prescription. We should have a copay for them. But if there's an inexpensive healthcare event and they have financial means, they should save in an HSA or have copays. And from here, you can kind of back into a design. I have a lot of clients who have rolled out $2,000 deductible plans with copays, where we're helping people see their PCP. We're helping them pay for their drug coverage. And the copay almost becomes a budgeting event because we're spreading the cost over the year. And what you can get to is a fairly inexpensive, more affordable design that's inexpensive for you as an employer versus an HSA offering and more affordable for the member. So I think this is a way to prioritize what designs you want. And then at the bottom, it's about, okay, what are affordability pain points outside of design? If it's per paycheck contributions, you might want to consider a catastrophic plan and think this is a term that's out there, but it has real out-of-pocket maximum protection. So every one of my clients, when we're talking about design, I go, what's the most you ever want an employee to pay out of pocket if something awful happens to them? And from there, that should be your out-of-pocket maximum in every plan, right? Because that's what health insurance is for. But if you do that, you could offer a plan that has no deductible, or excuse me, has a deductible and out-of-pocket that's the same, that brings the per paycheck contribution down and somebody has protection. The other thing we're seeing prevalent in the market is, can I pair my narrow networks or other strategy with copay-based plans to bring the employee contribution down? And that's for you all with a limit. Like if you have a geography where most of your employees are, it's a lot easier to execute that because you can figure out which health systems are in or out of the network. And this strategy here is, well, if you want that lower contribution or lower out-of-pocket costs, we're going to limit who you can see. So I think that's going to be a prevalent design going forward. On the income side, well, I'm not going to sit here and say you need to pay people more, but I do think you could consider job-based or salary-based contributions. I actually think job-based works better. And I'll give you an example of a client that I work with. They have a big manufacturing arm and a corporate workforce. Well, they said for their people in their plants, they're going to pay a lot less for healthcare than their corporate division. It's a little bit cleaner than income. So I have some clients who say below certain income levels, they pay less. The problem is, as people get pay increases, they might jump up an income band, and then it feels like they lost some compensation. So I think that job-based approach works really well. And then the other thing I'll mention is prioritize compensation in all your total rewards decisions in the near term. The overall labor market is still a cash-based labor environment. So I have some clients who are like, well, should I put more money in healthcare? I would say no, but it's more about how do I take what I have today and make it more efficient and optimize the offering to provide more affordable coverage without increasing the cost there, because still all of the labor force is preferring compensation over benefits. And that'll probably be the case for the next few years as things settle down.
Say, John.
So, yeah, go ahead, Ross.
Yeah, jump in with a question. Have you seen other creative solutions or ideas to specifically help employees who are in those lower income tiers beyond the job-based or the salary-based contributions? Have you seen some creative solutions out there?
Yeah, I mean, it's really tough because you have to provide them access to healthcare. I would say there are some employers who expanded their plan offerings to take advantage of the family glitch, which is an odd ACA provision where there's certain people that can qualify for a subsidy on the individual marketplace that weren't qualifying for the subsidy before because of some very nuanced guidance from the HHS. So some of our employers expanded their employer-sponsored coverage option to let people get access to that. So that's one way there because they can get a better deal there. But really, at the end of the day, it's about how do I make things more affordable for the lower paid people? And I do think the one thing that I would recommend for that is I would ask them. It sounds silly, but a lot of the times we jump to the decision point first and try to design things. And I'll use an example with one of my clients. One of my clients, they're a large health system, but one part of their population was just utilizing the healthcare system wrong. And when you start asking them, they basically did a focus group to that group and did a survey, and they found that it's more about health literacy and things like that, about what they were looking for, than anything of how we designed the program. So I'd also ask them, like, what do they need help paying for healthcare with? What don't they understand of the existing plan offering? How to make things more affordable, and then tackle it from that layer, because sometimes that can be just help you solve the problem, and it might not be as hard of a problem as you think to solve. So with that, those are all of my prepared comments. So if I was going to leave you all with something, and then I can open it back up for questions, is recognize the cost is going to go up, right? Because healthcare trends got to follow what we're seeing with the labor markets and inflation. The health system has to get paid. However, with that, there are some tactics that you can look at that will help minimize costs. I would look at things, I would ask your current carriers certain questions around pharmacy rebates, their performance with clinical management. I would consider, depending on your size and offering, market your plans regularly. So market your stop loss annually, look at things in the market as they evolve. If you have a limited geographic concentration, look at those local health system solutions where you can limit access but expand plan offerings. And then I would think about risk pooling strategies. So I would think about individual coverage HRAs. I'd always keep that because that's effectively a risk pooling strategy, or other things like that where you can expand your costs over a bigger base, right? Limits the amount of exposure you have to those high costs. On the affordability side, it's diagnose the problem. Think a little bit differently about plan design because there's a lot of ways you can tackle that challenge without adding cost. And then think about what the problems are. If the problem's income or paycheck based, I think there are solutions you can do around that problem to help your employees out. And with that, I will open it up for questions.
Okay, so since the room is a little quiet, I'll just throw one out there to see if anyone else has a question like this. But how do you really get started in offering? I guess I would say sort of like an integrated well-being program. I think a lot of the things that you talked about, with the cost of medication and deferring things because of COVID or but the increasing need for mental health, it kind of speaks to like really looking at the whole person in an integrated approach to health. Do you have any suggestions for really thinking about how to approach that part of the conversation?
Yeah, that's a great question, Susan, because I think that is the one place where employers can differentiate themselves the most. And we have to take well-being out of the benefit offering and embed it within the overall organization. So those are my clients who have the best well-being programs. And what I think about that is we have to think about how are those employees treated day to day, what type of leadership support we have that says that we have a very good employee experience that supports colleague well-being. And I'll give you some examples of like that's more tangible here in a second. And then think about what our benefit programs are doing is how does that support what the overall organization is. So it may not be we have what were traditional wellness programs where we had incentives where we're like saying, hey, if you do X, Y, and Z, a health risk assessment and those things, you're going to get $700 that you can use in an HSA or you can use to reduce your per paycheck contribution. Because then it's all tied to the medical plan and we're forcing people what to do. We might need to be thinking more about what program offerings do we have that support the organization's overall well-being initiative. So I'm working with a large client on this strategy right now because they have a traditional program where people do silly things. I know what they're doing because it's the same thing my company has where they're like, you log in your digital scale every day, we give you points and eventually you get enough for like $600. Well, what people are doing is they're just hooking it up for the money. It's not doing much. So what we're working with them on is to say, well, our benefit programs need to support well-being and our program offerings need to support it so we don't incentivize things. And what they keep saying back to their internal leadership is, well, if we still get after our call center employees and say, if we don't trust them when they call in sick or that their car's broken down, that it actually is broken down because the managers don't trust them, we can't solve the well-being problem. So well-being now is much more about how do we treat the actual employee and then what program offerings there are to support it. And the medical plan is there to support it as well then, which then you have to think a little bit differently about cost as well. Like we can't think, oh no, our cancer costs are so high because we have this, $500,000 member. We have to say, well, thank God we're paying for this person who can get the treatment and the program's there to support it. So I'd say those are what the leading organizations are doing. And then they're layering in things around the pillars of well-being, financial resources, mental health, spiritual resources for our faith-based organizations. The medical plan is just there. So I would say that's what the leading organizations are. And for my clients that do it best, one of my clients who does embed it within their culture, I told them to get rid of all their well-being programs that they had through the benefit programs. It's like they live it day to day. And that's the ideal end state for an employer to be from an overall well-being perspective, is that all the programs support what the organization is doing. I would say that does take some lift internally to make sure you have organizational alignment though.
Thanks, John. That's really helpful. And it aligns with what I've heard from some members recently too, is that as they focus on thinking about client-centered and how you can provide for the whole health and well-being of clients, if you're not thinking about the providers through whom those services are delivered, you're probably not going to actually achieve the outcomes you want with the client because you haven't really taken into account the person providing the services. So I think there's really excellent points.
Completely agree. And then for our financially oriented people like I am, what I'll say when clients do those things from a well-being perspective, the value you get out of that for the spend is like just pays off in spades. So I work with a client that's pretty large, a health system. They spend about $5 million on their well-being programs versus about $400 million in their medical plan. And the value they get out of the $5 million for their whole employee population for their well-being program, just astounding compared to what they're getting in the medical plan. So there is a financial equation to that as well.
Yeah. Hey, so we also had a question from Scott Cooper. I don't know if you saw that in the chat. And Scott, I don't want to misrepresent your question, so feel free to join in. But you had a question about high deductible plan with secondary insurance. And I guess the question is, John, what are your thoughts on those?
Yeah, I think Scott, and you can put it in the chat or chime in. I think I'd ask for the clarification on secondary insurance. Because typically what we see is if there's a second payer involved, meaning they're covered twice, the employer plan will be primary unless you're a small employer with Medicare. I've also seen some employers, it's not necessarily secondary insurance, but it's almost like they've figured out ways with almost coverage gaps. So they're like, we'll insure through an HRA, which I actually think this is a pretty good design. So I think it's a way to think about it. Think of like for the first $2,000 of coverage, we're going to put that through an HRA. Then our insurance plan kicks in. So you still have a deductible that might pay co-insurance up to a certain level. And it might be a higher dollar amount. And what it effectively does, if you think of your lower dollar claims, and then what you do is that secondary insurance above the deductible, you fully insure that through an insurance company. And what you're doing as an employer then is you're self-funding yourself through the healthcare reimbursement arrangement, the HRA. And then the rest of that risk you're buying through an insurance company, which is the unpredictable risk that's going to be more costly for you to self-fund. So if you're thinking of that, Scott, I do think that is a really good tactic, because what you, generally speaking, from an insurance perspective, you want to self-fund as an employer the risk that's more predictable, which is going to be your claims below a certain threshold. And then everything else is better to insure. And I would just say, like, what is the right level that you want to take on? The other good thing from a member experience is if you're funding 100% of the costs through an HRA, let's say up to $2,000, you're helping all those members get things done that they can for their drug costs, either PCP, all of that. The one thing I'll say, sometimes it's complicated for a member to understand that design, but I do think there is a place for that structure, because you're kind of bifurcating the risk or dividing it up in a way that makes a lot of sense.
Yeah, I had heard about, and I don't know the specifics of it, but basically where you are, like you're doing an HSA program or something like that with a high deductible, and that there's essentially a fund that when you get hit with that high deductible plan, that basically the organization is stepping in and being able to cover that high deductible, like you said, to a certain degree. You know, you'd have to put a cap on it, obviously, but that there's some level of being able to cover that gap. So the organization, in theory, is saving money through the HSA, but then turning around and providing some of that money back into a pool of funds.
Oh, interesting. Yeah, I haven't seen as much through the HSA. I've seen it more through an HRA. And to give you an example, what the design might look like, it might say, all right, the actual design you buy from an insurance company, fully insured, because this would be something you want to offload the risk on, might be, let's say, a $2,000 deductible plan with 80% employer co-insurance with a $6,000 out-of-pocket maximum, something like that. And it could even be higher than I've seen, up to like a $6,000 deductible. And then the employer's coming in and saying, okay, for the first $0 to $4,000, we'll give you 100% back through an HRA. And then between the $4,000 and $6,000 level, maybe it's 50% back. And what you're effectively doing then is all that high dollar risk goes to the insurance company, and you as an employer have what's left at the lower end. And I do think that is it's a nice way to move the risk around for an employee base. That way, if you can't afford to self-fund all the risk yourself.
Well, very good. Jon, thanks for sharing all the excellent information. Hopefully everyone found that helpful. I will just wrap up with a couple comments related to what Portico is doing. Portico has worked with and supported many employers, and we have found that addressing rising healthcare costs really requires an ongoing multidimensional approach. And for Portico, that includes spreading cost and risk across a larger pool. Today, Portico has about 17,000 covered lives in our health pool, which provides a direct benefit for participating employers. Jon talked about the navigator model. Since 2017. Portico has offered a navigator model, which really has helped drive better health outcomes through engagement and more efficient utilization. We've also done a lot of work around analytics to target and better manage chronic condition and high-cost claims. And then finally, preventative care along with condition management and wellness programs help to improve outcomes as well. So that's just a little bit about what Portico has done to support the various organizations that we serve. With that, I think at the very end, my contact information is part of this presentation. So if you have follow-up questions, feel free to get a hold of me. And I can certainly get a hold of Jon as well. But we really appreciate your time and you attending today's session.
Well, and I want to wrap it up by thanking all of our participants for joining us today, and for Ross and Jon for sharing your insights and your experience. And Ross, really just thank you so much for your leadership across not only Lutheran Services in America, but your Portico's commitment to the ELCA, and we really do appreciate your continued support. We'll be sending a follow-up email tomorrow from Kim, and we'll have information about upcoming webinars. We'll have how you can contact Ross. He's got his information there, but we'll put it in an email for you. We'll include the slides, and we'll also include a copy, or sorry, a link to the recording of this session today. And with that, just thank you everyone for a really wonderful webinar today. And we'll look forward to seeing you at another Strength and Service webinar soon.